Hey, everybody. We have people that are slowly moving into the room. How are you? I'm Kate Miller. I work for HawkTalk. I'm a physical therapist assistant. Many of you already know who I am and have seen me before, so I won't bore you with my story yet again. We have Capilli, Dr. Capilli here to talk to us about post-TKA and some interesting treatment techniques using iStim. And we have his patient here who I think it's so cool that he jumped in to join the webinar. He has a pretty incredible story, interesting story, if anything, that he'll talk to you about as well. So one thing that I wanted to mention to you guys first, we have our t-shirt program, our giveaway program. So if you share our webinar on social media outlets like Instagram, Facebook, LinkedIn, Twitter, which I don't do, and anything else that you can think of, any maybe social media outlets that I'm old, I don't know about, please share them. Hashtag HawkTalk Live. We'll contact you and we'll send you a shirt. Also, stay till the very end. We are giving away a couple cool things today. So stay until the very end and we will be drawing winners out and we'll contact you via email. I'm so glad that you guys are joining us once again. And I'm going to actually hand it over to Dr. Capilli, who's also one of our instructors for HawkTalk, and he's going to tell you a little bit about himself, and we'll get this webinar rolling.
All right, thanks, Kate. Appreciate it. Yes, my name is Capilli. I've been a clinician for 12 years, primarily in an outpatient orthopedic practice. I had my undergraduate degree from Canisius College in Buffalo, and then finished my master's and doctorate at UVille College, and then my fellowship in manual therapy from Damon College under Dr. Ron Shank. So been a clinician for 12 years. I've been using ISTM for about the whole time. I felt like I've used every tool known to man, really, from a spoon to you name it, that's out there. I've been using it for treatment. But of course, in my opinion, they've all been subpar until I started working with HawkTalk. I've worked for other companies. I've taught for other companies. I've been with HawkTalk now for 3 years, and been fortunate enough to be involved. Yes, it's been a great 3 years. So the reason I got into using HawkTalk or iStim, kind of that route, is because I'm always looking to better ourselves as a clinician. I think we're very fortunate to be in physical therapy, chiropractic, whatever field that you're in, that we have continuing ed out there that's going to constantly make us better. There's more research out there. There's more exercises. I mean, you've heard the cliche, there's more tools in your belt to use. Ever since I've been using these tools, the HawkTalk instruments, the benefits for my patients have just flourished, whether it's post-surgical, tendonitis, and so on and so forth. Of course, with any manual treatment, you can't just use that. You're going to use other Therex and so on and so forth. But go ahead, Kate. Let me just move on with the patient and keep talking.
Yeah, let's enter the patient. I'm stoked that you brought that a patient's willing to go live. Are you ready to meet the world?
Absolutely. So this is Chuck. I know we have listed up there some information. Chuck actually was a great case study for me a couple years ago. They have the link on the video there, so you can go back and read his case study. So Chuck was a patient of mine years ago. I'm going to give you a little bit of a history about Chuck. He's had a total knee replacement about November 2012. Didn't go well according to plan. Ended up getting infected a month later. Then after that was cleared up, Chuck went to physical therapy, didn't get the results that he was looking for. Was going through the typical Therex, manual therapy, doing some modalities and so on. So in February 2014, Chuck actually had a spacer put in, only to follow up back in May 2014 to have it replaced again. After that was done, they sent him back to rehab. It was kind of the same treatment, didn't get too far on that aspect. And then in October 2014, so it's now 3 surgeries now in 1 year, he ended up having it manipulated. I was fortunate to meet Chuck because I was actually treating his wife for something totally different, and Chuck was there and was watching us what we were doing, and I started using the tools, and it kind of piqued his interest. He's like, what are those? What do they do? So we kind of talked about kind of the treatments that I do with my total knee patients, and and he's like, what, let's give it a shot and see what we can do. So, just like with any of my total knee patients, to me, education's huge, especially when you're using the hawk grips or if you're using really any modality you're introducing, because, we were talking before this, doing this surgery, it's kind of like carpentry work on your knee. You want to put up that first picture there. So I always show the patients the picture of either what the knee went through, or if they can stomach it, I ask them, have you seen the video? Have you seen
Let's put it up.
actually what the surgery was and what it did? Okay.
Right.
So I want them.
Aloha 1.
Aloha. Oh, I'm sorry. Yeah, that was a code word. Aloha 1.
We had code words for pictures, and Aloha 1. Here's the first picture. Now, full discretion, guys. This is, we're clinicians. We've seen probably a lot worse than what I'm about to show you, but this is an open knee. So keep in mind, if you don't want to see this, just close your eyes for a second, and I'll let you know when the picture's down. So go ahead, Chris. Tell us about this picture.
So what I'm trying to show to the patient is, there's a lot of tissue disruption, obviously you can see. I want them to see this because when we're going through the rehab process, I want them to understand by using the instruments, we're realigning the fibers, we're bringing blood back to the area, we're trying to disrupt any of those adhesions. I always go through the analogy, I'm Italian, so I always like to use food references, right? That always works for everybody. So I always say, it's kind of like when you put spaghetti in a strainer. If you let it sit there, what's it do? And they say, oh, it clumps and gets sticky. Well, that's what happens. After your knee is repaired, and you can take it down, back to me. After it's repaired, you have a lot of those adhesions, a lot of that stickiness, a lot of that dehydration within the tissue. So then when you're trying to work this off tissue to allow for that full range of motion or whatever range of motion you can get out of it, there's restrictions, right? So I want them to really understand that. And what's great about using the hawk grip instruments is that you can actually see what you're doing. The patient can see that you're actually breaking the tissues up because of the road bumps, or however you want to describe it to them. They can see the petechia, so they can see the blood actually coming to the surface because you're breaking up some of those little capillaries that are in that tissue. And then they can actually feel the difference pretty much immediately. Okay. So of course, again, you're going to want to use that with Therax and other home exercise program and modalities and such. Now, back to Chuck. If you want to put Aloha 2 up for me, that'd be great. I want to show you Chuck's scar. Chuck's scar, when I saw him, was probably 14 inches long. Again, that's after 4 surgeries.
That's a pretty gnarly scar you got there.
That is a pretty gnarly scar. When he came in to see me, his active range of motion was -10 to 81. Okay, now Chuck is probably the most active person I've met in a long time. He works out.
He was golfing all day today, wasn't he?
Yeah, he's golfing, but he works out like 4 to 5 hours every day. He boxes. He's out walking, running, jogging, doing different things. Very active person. So this is really impeding his life. Yeah, right, definitely not making you feel good for sure. That's why I don't fit in my shirt. Anyway, so our treatment started using the hawk grips, using the tools. Like I said, we incorporated different modalities and such. Visits 1 through 5, we got him from -10 to 81. He went to -3 to 94 degrees. So that was huge. We just jumped in 5 visits. We jumped 14 degrees.
How often were the visits? Did you guys do bi-weekly? Did you guys
twice a week? Okay. We did twice a week. Yep. Actually, if you want to show Aloha 3 for me, that'd be great. So you see some of the techniques that we'd use now. We use the scanner as well as the clean presser. Again, food references. We call this the biscotti. So this is the we use.
I have heard many names for our tools. I've never heard biscotti. I have never.
Biscotti. Oh, that's classic. That's classic. Biscotti. Was it Tumbo was the other one? Hawker's biscotti.
I love it.
We use the tool going in all different directions. As we know, the quadricep muscle, we want to make sure that we're going in all different directions, proximal to distal, medial lateral, and so on and so forth. I always start my patients in open chain position, more of a full knee extension as much as they can get, and then I progress more into flexion. And I want to demonstrate that in a minute here. Again, making sure that he's full aware of what we're doing. He's actually seeing the technique. And then we want to show Aloha 4. After 5 to 10 visits, Chuck was able to get -2 to 98 degrees. Okay, that's using the tongue compressor. Okay, the tongue compressor was able to get a little deeper, able to go over that scar matrix and break up whatever tissue that I found in terms of any specific adhesions.
Do you call this a breadstick, or what do you call this?
I didn't call it breadsticks. That's pretty darn good. You're making me hungry right now. I stuck with the tongue compressor. I was trying to make it, because when I threw this in the class, people were getting distracted, so I had to stick to the typical tongue compressor. After doing that, we would incorporate, you can go to the next picture, Aloha 5 there. We were doing other like leg press. We started working more closed chain with him. Once we got up to 98 degrees, after about 10 degrees, get the other picture there? No? All right.
Aloha 0.
More Aloha 0. More closed chain. We did squats. We used a lot of TheraBands. Of course, throughout this whole time, using the TheraBand tape, which is helping to keep everything that we worked on, keep it more consistent. Chuck had a lot of exercises to do at home. So pretty much this is just it's an extra tool to carry, extra tool in your belt, like they always say. But right now what I want to do is I want to have Chuck get on the table. I want to show you a couple of things that we did. But while he does that, I want to talk about some of the precautions.
One thing that I wanted to ask you about real quick is, so I've worked in, orthopedic, inpatient, outpatient. So I've seen total knee day 0. I've seen total knee, 2 years post, umpteen surgeries, kind of like Chuck's situation. What is your thought? And I'm hoping that clinicians understand that you can put your hands on a patient day 0.
Yes.
Have you utilized the tools in an acute care situation, such as day 0, 1, 2, 3? I know I have in a hospital situation, but I don't know your experience.
Well, so since I'm in an outpatient setting, I'm usually getting them probably, 7 days out. Yeah. But I would use the day 1 in terms of that. So day 1 outpatient with the sutures in there, sutures out. Obviously, you want to be aware of What's that?
Obviously, you don't go over the sutures. We're not going to,
No. Obviously, you're going around it. But you also want to make sure if they're on any blood thinners, Coumadin, things like that, you're keeping that in the mind. If you have to, I'd use the flat part of the bevel or go more proximal or distal, staying away from maybe if there's some swelling in there. But that's a common question I get in the courses is when can you start? When's a good time? Is there a time frame? Do you do it every time or do you visit? Again, let the tissue dictate how much you're doing. Okay, have the patient dictate how much you're doing. If you start to see it's getting disrupted or the patient's getting uncomfortable or maybe you're not getting the results you're getting, maybe you want to back off a little bit. Or the opposite, maybe you want to increase. So, of course, we're using our HawkHydro plug or the HawkHydro Plus, right, for using our tape. To the side. Okay, so I don't know, can you get a good shot of his scar there?
There we go.
See it better? So what I would do is, like I said, I usually have them supine and then would work into it, but just for demonstration purposes, I'll have them here off the side. So what I do first is I'll have the patient actively pull back as far as they can and then lock them there with my foot or my leg, okay? And then what I'll do is I'll say, where do you feel it restricted? And then they'll point and they'll say, here or here. And then I'll start working in that area. And they'll say, all right, I'll release them a little bit. And then I'll say, all right, let's have you move back a little further. Tell me, how far can you go back now? Whether they increase or don't increase, they'll say, oh, I don't feel it there. Now I feel it over here. Okay? Not into chasing pain at all, but at the same time, I also want the patient to identify to me where they're feeling their restrictions. And then we'll pull them back out into extension, and then we'll start all over again.
Awesome.
Okay? So what we'll do is we'll start with the biscotti or the scanner.
I tell you something, I make a mean biscotti. I'll have to send some to you sometime.
Yeah, you should.
Oh, yeah.
Absolutely.
My nickname in high school was Noni, even though that means grandmother. But my last name, my maiden name is Nono Mura, so they just called me Noni because I made biscottis.
Oh, beautiful. There's some Italian there.
I married one.
There you go. So again, we're going to use, I don't want to block you here, but we're going to go proximal distal. So the majority of the time we're getting distal quad, right? And then you're going to get it also more towards the patellar tendon. So we're going to go in different directions. We're going to do all our different strokes, our fanning. Okay, you can do the double fan if you want.
Hey, Chuck.
Sleeping. Yeah.
When he first put his hands on you, you were what, after your third surgery? So it was.
Well, I actually had 5 surgeries, and the last one was to get rid of some of the scar tissue.
Okay.
But it really didn't help at all. And when I first met Chris, I'm always on the internet looking for some ways to improve at the time.
Mm-hmm.
And I seen these tools being used, and I asked Chris about it because he was treating my wife. And he said, "Oh yeah, I do that." So I started getting treated by him, and I had immediate results.
That's awesome. So was it?
I mean, he had, I mean, in 10 visits, he had an increase of, let's say, 81 degrees to 98. I mean, that's pretty, for someone who hasn't been treated since 2014. I saw him in 2016, 2 years later. He's been going through, he said, 4 or 5 surgeries. So what happened was he talked to his physician up in Rochester, and they thought this was great. So we ended up actually having a class up there. And this is something also for the viewers out there. If you are using HawkTalk for the first time, or just for a marketing purpose, get into your ortho docs. I bring these to our ortho physicians, and they love it. I go to each physician and I use it on them first, make sure they understand what it is, and they fall in love with it. I'm getting scripts now that say HawkTalk.
That's awesome.
So
I think, one thing that I remember even when I was an aide, it was doctor's protocol for every different. Now the rehab world has changed in
Right.
10 years, whatever it is now for me. But a lot of doctors have specific protocols now. No longer do we just do long arc quad, hamstring curl. Like we're way outside of the box at this point. But he makes a good point. Bring patients, if patients are watching, clinicians, bring it to your ortho and say, hey, this is what I'm doing. This is why or at least one of the reasons why my patients are getting this many, this result.
Right. I mean, and the reason I did that, I'll tell you a quick story. Years ago, when I first started using this, got a phone call from the angry doctor. He's like, "Chris, why are you using putty knives on my patients?" And I was like, "All right, hold on." I said, "I'll be right there. You have to see what this is." And they fall in love with it. I mean, I actually had patients come from an hour and a half away just to be able to get a treatment. Getting referrals. I mean, I don't know how many referrals he's sent me. He's my direct referral right there. I mean, we're having, the research shows we're having 700,000 total knee replacements done a year in the U.S. But they said there's 3.5 million a year by 2030. That's a lot. So
Well,
I mean, this is just
that are now getting them more and more as well. So I mean, that makes it.
plus that's job security for us. That's perfect, right?
Well, if I can, I'd like to throw something in there. After I got my second knee replacement, okay, my tendons had detached from the bone. So my doctor, an orthopedic surgeon, he had to reattach my tendons. When I came out of surgery, I had a brace on my leg and he restricted my movement, so I couldn't do no rehabilitation whatsoever. So two years after that, I met Chris, and he did this with my knee. And my orthopedic surgeon basically told me that he didn't think it was a possibility of me ever regaining any movement or straightening my knee any better than it was at the time. So, I'm just thrilled beyond belief that I'm able to, at my age, do the things that I want to be able to do. And, he's helped me so much.
I think that's awesome. You have to give yourself some credit because you have to give yourself some credit too, Chuck. Like you took initiative, which if there are patients out here listening, take initiative. We have on our website, we have find a provider. So if you're in, even if you're in Canada right now listening, or if you're in Florida right now listening, go to our website.
New York, right?
Or New York. Come see Chris.
Another thing I got to say is don't listen to your orthopedic surgeon when he tells you that you cannot make gains after that 16-week window, because it's very possible for you to be able to bend your leg better, straighten your leg better out, fix your gait out better. These products actually help me considerably. There's no doubt about it. I put the time in, but you still got to be willing to do the work yourself.
That's awesome. I really appreciate that, Chuck. We're going to post on here the Find a Provider link that, again, you can find on our website, but you can locate a provider anywhere in the United States, Canada, anywhere that there is a HawkTalk, you can find them. So if you're a patient or a provider like a physical therapist, DC, clinician of any kind listening that, you do this kind of work for us, or you already use HawkTalk and you're looking for a way to help more patients, make sure that we have you on there as a provider.
Absolutely. And just in addition, we even talked about his extension. He went from -10 to -2. And that's huge.
That's
increasing
awesome.
the extension and his flexion the way we did, it just unlocks everything more proximal. Now we can work along the whole kinetic chain. We can work on his glutes, his hamstrings. It just goes on and on. To the point where now he's independent with his exercises. He's back to boxing. He's back to golfing. He's retired. He's a retired correctional officer. He's back living his life, with his family and doing what he wants to do. So it's another success story. It's another HawkTalk success story. We're seeing these daily. I can't emphasize it enough. When I'm in class and I'm showing these tools to the attendees who are going through different examples, I mean, there's nothing like having something at your disposal that you can use the next day in the clinic, and it's a positive. You know what I mean? So it's something that helped me in my treatments. I'm using them probably almost with every patient, especially also that using the TheraTape and other interventions, but definitely a benefit.
We have a question. So
Yes.
Is there an active movement that, obviously past the acute stage, obviously somebody who is able to do squats and other active movements, maybe more dynamic movements as well. Is there a specific technique utilizing HawkTalk's tools, whether it be any of, the Biscotti or any of the other ones, that you can show us with Chuck? Maybe something a little dynamic that helped him?
Sure. At this point, because we're kind of limited being in the room, but what we're going to do is just stand up. I have the TheraBands in here. We did work with TheraBands. We worked with leg press, but not rolling up. Yeah.
Who wears short shorts?
Yeah, right. He does right now. So bring this leg a little forward. So what you do is we'll have you do about 10 squats. Okay. So as Chuck is doing a squat, go ahead, down and up, as long as you can. I'm working the whole way up. Can you see that pretty good?
Mm-hmm. Hi, Chuck. Bye, Chuck.
Let me move out a little bit. Okay, you can use this. You know, Chuck. I can bring in the handlebars. First, I come on the other side of the foot, Chuck. Squat. Yeah, keep going.
So one thing that I want to share is that, if you have restriction in movement, whether it be from somebody like Chuck who has had a lot of different experiences in terms of surgeries and I'd say maybe complications. If your knee is restricted, it's going to affect the entire kinetic chain. So you don't always have to treat the knee. If you're using HawkTalk such as the handlebar, were there any kind of techniques that you utilized to open up his hip or low back even?
Yes, I'm a huge proponent for the glutes or the driver of the whole lower extremity. They're the engine of the body, right? So if there's anything distal of that, I'm always looking at spine first. I don't care if it's total knee, total hip, whatever it is. So like I said, I did address this, but it opened everything up proximal as well. So we did a lot of glute med, clam shells, and then glute sets, things like that. I always started in open chain first and then progressed to more to closed chain. I didn't want to jump right to closed chain even when doing the squats, because then he'll just start getting those compensations will start to kick in, and he'll start taking that path of least resistance that we don't really want to see. Okay. Will make him feel better that day, yes, but he's going to return with the same issues. So yes, we did some low back mobilizations. Like I said, I had my fellowship in manual therapy, so I did a lot of manual work in his low back, some manipulations and such. Worked on his hip, got the hip mobility back, worked on some capsular mobs too, and incorporated that. And once we start getting things moving, another thing I'm seeing with patients with total hips is upper thoracic restrictions, because they're so guarded when they walk that they're not getting that trunk rotation. So when you don't get that trunk rotation, it's just going right up the chain, which brings up a question is where do you stop? I mean, are we going all the way up and doing a screen to the top? I mean, if you're watching someone's gait and you're doing a proper gait assessment with somebody who has a total hip or a total knee, you're going to see that limitation.
Yep.
Yeah, that type of thing, or that any of those types of dances you do.
Actually screwed my back through. Like I said, when Chris started working, my back was a mess. My feet was a mess, and this improved it. Not a little bit. It improved it a whole lot.
That's very cool.
Significantly. And you know, I'm just pleased. I'm very happy. It's nice to get your life back. You know what I mean?
That's
When
awesome.
you can't walk up and down stairs and you can't stand for long periods of time, it kind of limits you on what you can do. Because I like to go see shows and stuff like that. A lot of times you're standing up. You got to stand in one place for a long time. It affects your back, it affects your feet. Since I've had this done, it hasn't restricted me. I can do these things now.
Stories like this are what I do.
We had our treatment during football season. Since he's a Giants fan, he had to tell me to back off. I'm a Cowboys fan. It didn't work out well. It was like oil. You know, it didn't work. Like back off a bit.
Because he has such a great story. I mean, stories like this are why we do what we do. I won't say anything about you being a Giants fan, me being a Pats fan.
You can throw that in there.
I'll leave that alone. But one thing did you ever put him on a bike? I know being a little less acute than the average total knee that you see. I don't know if you ended up having to do it or not, but I have utilized, the typical rock your knee on the bike.
Yeah, we actually have new steps. We have the new step machine, so it's kind of like a recumbent new step machine. So the thing I like about that is that you can use your arms too. So that'll at least allow more motion back and forth. Lots of tools out there, and use them out in the gym. Yep. Use them out there. Once you bring it on the gym, you get noticed by every patient out there. So what are they doing with those tools? So that's also a benefit as well. You put them on there, got them going. That was his warm up. Bring blood to the area. Once you bring blood to the area, you're doing part of what the tools are going to do for you. Then you go in there, and then you get that mechanical change as well as the neurons. So worked out well. And for those watching, there's the link up to his case study. It's more detailed. This is what we did with more pictures, more alohas on there. You can check that out and get more information.
Awesome. Well, I really appreciate you guys coming on today. I know that like I said before, we've come a long way from total knee, the assembly line type of get a patient in there, put him on heat, get him to do a long arc quad, stretch the hamstring, blah, blah. And I can't say it enough. It used to drive me nuts. Everybody was the same protocol.
I always say, if I ever become a stagnant therapist where I'm doing that same thing, I'm retiring. I'm done because, it's just, it doesn't help us as clinicians. It doesn't help the patient. This is you have to have a forward way of thinking.
Yeah. No, but I'm so grateful
that some of those things that you just said, I had them done by my first physical therapist, who was a great guy, but I wasn't getting the results for the work that I was putting in. Matter of fact, some days I'd leave there and I'd be at say 80 degrees bending my knee. I'd go back the next time for a session, I'd be at 83 degrees. So I'd actually lost what I gained that day, through the treatments I was having done. I mean, this is the only thing that's helped me. This is the only thing that has helped me. This is 2 years after my second knee replacement, when I was restricted from doing anything. So very happy with the result. Very happy.
And full caveat, we're not paying him to say this.
I know you're not. I did. But I did come up to get a treatment for free today.
He came back to get more. All right, gentlemen, we're going to wrap this up. But we have put up Chris's information, so you can check him out on Instagram. You can check out, like I said, our located provider. You can check out his article that we also have posted on our website. You can check him out on LinkedIn. We also posted your LinkedIn on here. And of course, if you have any questions, you can reach out to me, kmiller@hawkrips.com. You can contact me any hour of the day via email, and I'll get back to you as soon as possible. And gentlemen, I really, really appreciate you out there in New York joining us today.
It's warm up here. We're happy today.
It's about 95 where we are. I'm roasting.
It's only 70 here. I'll rub it in.
All right, guys. Thank you guys all for joining our webinar. We will see you next week.